Welcome to this podcast on fracture with extension into joint. There are two reasons that we're going to go over today why fracture with extension into joint is important. The first reason is shown on the illustration there or on the radiograph there on the left. You can see that there's a fracture of the base of the thumb, in other words of the first metacarpal, and you can see that there is subluxation of the distal aspect of the thumb metacarpal in a radial direction. So one of the things that fracture with joint extension can result in is instability, and we'll talk a little bit about that and illustrate joint instability after fracture with the with this example of the base of the thumb. The second reason that fracture with joint extension is important is illustrated by the two radiographs there on the right. The middle radiograph there is a normal knee, and on the right is an abnormal knee. You can see that there is very severe narrowing of the medial compartment of the joint space on that far right image. And that's another thing that can happen after you have a fracture that extends into a joint. You can end up with premature osteoarthritis, a very severe osteoarthritis down the road. And those are the two things that we're going to talk about. Let's start off by talking about instability. This particular fracture here is known as a Bennet fracture, and I've labeled the trapezium there, and you can see that there's a fracture going through the thumb metacarpal, and you can see that that has resulted in subluxation of the larger fracture fragment in a radial direction. Not every single fracture that extends into a joint demonstrates instability like this, but this is a very classic example of a fracture that goes into a joint with resultant instability. And this is the reason why you have that instability. What happens is you end up getting unopposed pull of a muscle. So normally you have the situation as illustrated there on the left where there's no fracture involving that first metacarpal, and you can see that where the abductor pollicis longus tendon would insert, and basically the abductor pollicis longus tendon can't pull the remainder of the thumb in a radial direction if there isn't a fracture involving the base of the thumb. But if you fracture the base of the thumb, that first metacarpal, what happens is that abductor pollicis longus tendon can then pull the thumb, the remainder of the thumb, in a radial direction, resulting in instability. Now, the Bennet fracture does that classically, but you can have another type of fracture called the Rolando fracture, where instead of having just two fracture fragments like you have with the Bennet fracture, you have lots of fracture fragments. In other words, you have comminution of the fracture. Again, the other thing that we need to worry about in patients who have fracture that goes into an articular surface is premature osteoarthritis. And what I'm showing here is the distal radius, and you can see how smooth that articular surface is of the distal radius. And you can imagine that if you have a fracture that goes into that very smooth articular surface, that would disrupt that normal smoothness and would put people at risk for premature osteoarthritis. So I've circled a fracture there of the distal radius, and you can see that that fracture goes into the joint space, and you can see that there is, especially on that lateral view, some distraction of that fracture, and the wrist doesn't do well when you have fractures that go into the articular surface. That puts you at high risk for premature osteoarthritis. Even very small amounts of distraction or displacement are not good, and the orthopedist will do whatever they can to try to restore anatomic alignment. Very important to do, because obviously you use your wrist all the time, and the wrist does not tolerate small amounts of displacement like this. You need to correct those surgically. One thing that we don't see very well on x-rays is cartilage. So I want to illustrate with this example here of something that we don't see well on an x-ray, but we have to infer on the basis of our radiographic findings. On the left you can see a coronal image from the Visible Human project showing a knee, and on the right are two images that I've sort of extracted from the image on the left, focusing on the tibial plateau. The upper right image is normal, and you can see that there is normal articular cartilage. The image there on the bottom on the right, what I've done is I've gone in there and I've created a fracture using Photoshop of the tibial plateau. and you can see that what happens is that you disrupt the articular cartilage. Again, that's not something that we see directly on an x-ray, but it's something that we can infer by our knowledge of anatomy. Now, the tibial plateau is an area where you definitely don't want to have premature osteoarthritis, because obviously this is something that we depend on to walk around on. And if you have premature osteoarthritis involving the knee joint, that's going to be a source of significant morbidity. Very common way of fracturing your tibial plateau is to have a blow to the lateral aspect of the knee. In other words, a valgus force. And that valgus force will result in a compression force or compressive forces involving the lateral aspect of the knee, and that frequently can cause fractures of the lateral tibial plateau. Fractures of the lateral tibial plateau are a lot more common than medial tibial plateau fractures. First of all, it's a lot easier to get whacked on the lateral aspect of the knee as opposed to the medial aspect of the knee, and because the lateral tibial plateau is somewhat weaker than the medial tibial plateau. So this is what might happen after a blow to the lateral knee. So we've got two images here. On the left, just basically showing the mechanism of injury. You've gotten a blow to the lateral aspect of the knee. That's resulted in compression forces acting along the lateral aspect and tensile forces acting along the medial aspect. And if there's sufficient trauma, if there's sufficient compressive forces, what will happen is that the lateral femoral condyle will smash into the lateral tibial plateau and cause a comminuted fracture, as you can see on the image there on the right. Now, sometimes these fractures are pretty subtle. You can see on the image on the left, on the plane radiographic image, that there's not that much displacement of the fracture fragments. The CT scan on the right confirms that you do in fact have a lateral tibial plateau fracture, but that there's not a lot of displacement of the fracture fragments. And it may be that there's not enough displacement of the fracture fragments and not enough depression of the fracture fragments to justify operative intervention. This person might do just fine without operative intervention. This case obviously is going to need operative intervention. You can see that the lateral tibial plateau there is severely disrupted. You can see that there's sort of a gap in the central aspect of the lateral tibial plateau. So this person is going to have surgery to restore that normal tibial plateau, or to recreate as best as possible a normal anatomic configuration there of the lateral tibial plateau. If you don't do that, obviously you're going to have severe disruption of both the cartilage and the bone, and that's going to put this person at risk for very severe osteoarthritis down the road. CT images can be very useful in showing the degree of displacement of fracture fragments, the number of fracture fragments, and the depression of fracture fragments. The image on the left is a coronal reconstruction, and the image there on the right is a sagittal reconstruction. And you can see that there's quite a lot of inferior displacement of the fracture fragments, and obviously in this case you're going to have operative intervention to restore the normal anatomy of the lateral tibial plateau. Lateral tibial plateau fractures may occur due to forces beyond that, or in addition to that valgus force that we talked about. It may also occur due to an axial load. And if you don't remember what an axial load is, I would recommend that you go and look at the podcast on cervical spine injury. This person here jumped out of a second-story building. The image on the upper left is of the calcaneus, and there's an intra-articular fracture involving the calcaneus. The image on the bottom left is a normal calcaneus for comparison. This person would be at high risk also because of this mechanism of injury for fracturing the tibial plateau also. And the other thing that this person is at risk for is lumbar spine fracture. So this axial load, this jumping out of a building, puts the tibial plateaus at risk, puts the calcaneus at risk, and puts the lumbar spine at risk also. So this is something else I think you need to keep at the back of your mind with this type of fracture that extends into the joint space. L1 and L5 are fractured. You can see that on the lateral view of the lumbar spine there on the right. If you're having difficulty seeing those fractures, this image is also included in the discussion of the cervical spine fractures, and I'd recommend that you look at that podcast as well. Finally, something that can tell you that you do in fact have a fracture that extends into a joint is the presence of a joint effusion. Now these are some images that I've taken from the podcast on elbow fractures, and I'd refer you to that podcast as well to get the full story. The image there on the left is a normal lateral view of the elbow, and the image on the right is a patient who has a joint effusion, which you can see because of the distended fat pads. But again, that's another clue that you've got a fracture that extends into a joint. And obviously, if that fracture that extends into a joint is sufficiently displaced, someone can end up with premature osteoarthritis. That ends our discussion of fracture with extension into joint.